Hello everyone, and welcome to another chapter of Advanced Pathophysiology. Today we talk about Chapter 27, Sexually Transmitted Infections. We will be reading the entirety of this chapter, so without much further ado, let's jump right in. Newly acquired sexually contracted infections affect more than 20 million Americans per year, and half of those individuals are younger than the age of 25. STDs, or STIs, account for nearly $16 billion in healthcare costs in the United States. They have been called the hidden epidemic by the CDC because they are so prevalent, yet rarely discussed. Complications of STIs include short and long-term morbidity, and even mortality that can affect physical, emotional, and financial well-being. As always, with these like what's news, feel free to hit pause and review them. Here's a report from the 2015 CDC report. In the past, an infection transmitted through sexual intercourse was called a venereal disease. However, the term venereal disease has been replaced with STI. STIs are contracted by genital contact or through contact with infected blood or body fluids. Infections can be transmitted directly through touch, or the infectious agent can be transmitted by an object known as a fomite. STIs also can be transmitted from mother to child during pregnancy and birth, a process known as vertical transmission. Many infected individuals are not screened for STIs because symptoms are absent, minor, or transient, or because health services are inaccessible, unaffordable, or culturally insensitive. When individuals do not know they have an STI, they often fail to prevent transmission to others. With adequate screening and early treatment and education, the prevalence and sequelae of STIs can be greatly reduced. Behaviors are the greatest risk factors for STI acquisition. Individuals who have unprotected intercourse or genital oral contact, especially with non-monogamous or multiple partners, are at greatest risk. Certain populations are defined by age, behaviors, geographic location, traits, or race ethnicity, have a higher incidence of STIs. This increase is usually a result of increased risky behaviors by individuals in this group, but it can also be due to physical or cultural characteristics that contribute to transmission. An example, the rates of gonorrhea, chlamydia, vaginitis, cervical condyloma, genital warts, and pelvic inflammatory disease are the highest in adolescence and decline exponentially with increasing age. Adolescents are more often engaged in risky behaviors and have a greater number of sexual partners than older adults. People entering correctional facilities, such as jails, also have higher rates of STI prevalence related to their risky behaviors before incarceration. So here you see the incidence of STIs by age. Some populations are at greater risk because of the pathophysiology of STI transmission. Transmissions of many STIs is enhanced when the infectious agent contacts mucous membranes, such as the mouth, oropharynx, vagina, rectum, and the inner foreskin, which provide a more favorable environment for transmission than skin. Therefore, women, uncircumcised men, and men who are receptive partner in oral or anal sex are at increased risk. In addition, prolonged contact with infectious body fluids also increases transmission, which occurs when semen is deposited in the vagina or rectum. Young women are at greater risk for STI acquisition when compared with older women, which is related to the position of susceptible cells on the surface of the cervix. STI transmission is enhanced when the infectious agent has contact with broken skin or blood vessels. Therefore, sexual contact that is damaging to the genitals increases STI acquisition. This is the case with rectal penile sex, or as well as forced genital contact. Broken or friable skin caused by genital infections or trauma also can increase the risk of STI acquisition. As a result, if an individual has one STI, he or she is more susceptible to the acquisition when exposed to other STIs. Race and ethnicity are not factors in STI acquisition. STIs are prevalent in all socioeconomic and racial ethnic groups. Publicly available data suggest a greater prevalence in minority groups or among people with low socioeconomic status, which may be a reflection of greater STI reporting from public clinics that serve marginalized groups when compared with private providers who are not required to report all infections to authorities. Race and ethnicity alone do not alter STI risk, but rather act as risk markers that correlate with other more fundamental determinants of health status, such as poverty, access to quality care, and health-seeking behavior. In some geographic areas, racial, ethnic, or socioeconomic groups may be more or less likely to engage in at-risk behaviors, such as intravenous drug use and unprotected sex. Healthcare providers should provide risk-appropriate screening based on behavior and physiologic risk factors without racial profiling. To assist clinicians, the CDC regularly publishes a comprehensive guideline detailing STI screening, evaluation, and treatment that specifies current at-risk groups. This guide and its corresponding smartphone app are the best sources of current information on STI screening and treatment, since this area of clinical care changes rapidly. An STI can be caused by bacteria, viruses, protozoa, parasites, and fungi. Transmission rates and prevalence depend on characteristics of the pathogen and complex factors associated with behavioral and societal factors. Bacterial, protozoan, parasitic, and fungal STIs can be successfully treated once diagnosed. However, viral STIs cannot be cured by pharmacologic means alone, and depending on the virus, affected individuals have the potential to carry or transmit the virus throughout their life. So here at this table is a good spot to hit pause so you can review all the currently recognized STIs and their causal microorganisms and their infection. Treatment or symptom management of STIs depends on the causative pathogen. Treatments change frequently based on drug resistance and availability of medications, and are personalized on the basis of the individual's medical needs and their personal preference. Treatment of the person and his or her sexual partners is often complicated by inadequate access to medical care, drug cost, and privacy concerns. Many states have enacted legislation to allow sexual partners to be treated without having to go to a clinic for an examination and prescription. Prevention of STI acquisition involves a multifaceted approach, including encouraging behavioral changes to decrease transmission, such as decreasing the number of sexual partners or using condoms. Pre-exposure vaccines, including vaccines for hepatitis and HPV, have been used to protect populations against viral STI before exposure. Medications also may be used to prevent acquisition of STIs as pre-exposure and post-exposure prophylaxis, especially in the prevention of HIV acquisition. Early treatment of STIs prevents transmission to new hosts and decreases the risk of additional STI acquisition for the index person. Testing and treatment are especially helpful in preventing vertical transmission. So, we can start by talking about sexually transmitted urogenital infections, our bacterial infections. Starting off with gonorrhea. Gonorrhea is caused by gonococci, gonococci, a microorganism of the species Neisseria gonorrhea, first identified in 1879. Gonorrhea became the most widely reported STI in the United States before entering a decline because of widespread availability of testing and treatment. After reaching a record low in 2009, the rates for gonorrhea have increased 10.5% since 2010, in part because of widespread testing using more accurate nucleic acid amplification tests. The risk of developing gonorrhea from intercourse with an infected male partner is 50 to 80% for women, and with an infected female partner, it is 20 to 30% for men. The risk increases threefold to fourfold for men after 4 exposures to an infected partner. Men who have sex with infected men have a greater risk of contracting gonorrhea if they are the receptive partner. Transmission of gonococcal infection generally requires contact of epithelial surfaces, such as occurs during vaginal, oral, or anal intercourse, and infection in adults can be maintained in the vagina, rectum, or pharynx, or urethra. A pregnant woman also can transmit gonorrhea to her fetus through infected cervical and vaginal secretions, contacting the baby's mucosal surfaces during birth. Following vertical transmission, the newborn eyes can be infected and can result in blindness if left untreated. Treatment for gonorrhea is becoming more difficult because of rapidly developing resistances to available antibiotics. Both the CDC and the World Health Organization advise dual drug treatment for gonorrhea to effectively treat infection and staunch increase in resistance. This antibiotic resistance is increased in populations that frequently have oral or anal receptive intercourse, such as men who have sex with men. The CDC states that it is reasonable to expect that gonorrhea may become resistant to all known antibiotics in the possible near future. The pathophysiology. Humans are the only natural host for gonorrhea, an aerobic, non-spore forming, oxidase-positive, gram-negative coccil microorganism that usually appears in pairs with adjacent, slightly flattened sides. Hair-like filaments, called pili, appear to help the microorganisms attach themselves to host cells, the epithelial cells of mucous membranes. Columnar transitional and stratified squamous epithelial cells are most often infected. First, the microorganisms become attached to the plasma membrane of these cells, and then they invade the cells and begin to damage the mucosa. Generally, a quick leukocytic response and exudative at the site of infection occurs. So here is a picture of gonococci. In women, the endocervical canal is a common site of initial gonococcal infection, although urethral colonization and infection of glands near the urethra and vagina also are common. Several factors facilitate ascent of the gonococci into the uterus and the fallopian tubes, where they can cause PID. Among these factors are the disintegration of the cervical mucus plug and an increase in vaginal pH to greater than 4.5 during menstruation. Uterine contractions that may cause retrograde menstruation into the fallopian uterine tubes, and various microbes that possess virulent potentiating factors for chlamydia or gonococcal PID. Bacteria also may adhere to sperm and be transported to the fallopian uterine tubes. Once gonococci are in the fallopian uterine tubes, progressive mucosal and submucosal invasion of the tissue causes sloughing of normal ciliated tubal epithelium and a marked inflammatory response, causing the tubes to fill with exudate. In men, the, the gonococci typically infect the urethra or rectum. Untreated urethral infection can cause epididymitis in men and potentially lead to urethral stricture, fistula formation, and sterility. However, a few men maintain asymptomatic infection for long periods of time. Concurrent or isolated oropharyngeal and anorectal infection can be found in infected men and women and may be difficult to detect with common testing mechanisms. These sites are associated with greater antibiotic resistance than urethral or vaginal infection and may need additional treatment and monitoring. One hypothesis for the increase in resistant strains in populations with a high prevalence of oral and anal intercourse is that the oral and rectal mucosa normally contain many non-pathogenic forms of Neisseria bacteria. These bacteria are often exposed to antibiotics used for other non-STI conditions. However, instead of being eliminated, they develop antibiotic resistance. Gonococci frequently share plasmids and DNA across species, facilitating the transfer of antibiotic resistance. When the oropharynx and the rectum are infected with N-gonorrhea, the pathogen becomes in contact with antibiotic-resistant bacteria that share plasmids and DNA. As the N-gonorrhea proliferate, they can acquire antibiotic resistance before being spread to new individuals through oral sexual contact. So what kind of clinical manifestations do we see in gonorrhea? The clinical manifestations of gonorrhea can be categorized as local or systemic and uncomplicated or complicated. Uncomplicated local infections include urethral infections in men and urogenital infections in women. While infection can initially be asymptomatic, the majority of infected men will develop painful urination or purulent penile discharge, or both. Within a week of infection, these severe symptoms encourage most men in developing countries to seek treatment. However, some men only have a little discharge or urethral itching, and 5 to 10% never have signs or symptoms. Most cases of untreated gonococcal urethritis resolve spontaneously after several weeks, and more than 95% of individuals are asymptomatic by 6 months after infection. In women, the incubation period varies, but those who develop symptoms usually manifest within 10 days of exposure, or 1 to 2 days after the next menstrual period. More than half of gonorrhea infections in women are initially asymptomatic. Symptoms often do not appear until the infection has spread to the upper reproductive tract. Symptoms can include dysuria, increased vaginal discharge, abnormal menses, dyspareunia, lower abdominal pelvic pain, and fever. Physical examination may disclose cervical friability and erythema, and mucopurulent discharge from the cervical os. There may be discharge from the paraurethral or greater vestibular glands if these sites are involved. So here you're taking a look at the gonococcal cervicitis. Anorectal gonorrhea occurs more commonly in MSM, but also is found in women, both as an isolated finding and with coexisting urogenital gonorrhea. Symptoms of anorectal gonorrhea range from mild anal pruritus, mucopurulent rectal discharge, and slight rectal bleeding to severe rectal pain, tenesmus, and constipation. Physical examination findings include anal erythema and discharge, and evidence of mucosal damage to the anus and rectum, such as friability, edema, and purulent exudate. Gonococcal pharyngitis occurs after oral sexual contact with an infected partner. Symptomatic pharyngitis is indistinguishable from any other bacterial pharyngitis and can include fever, lymphadenopathy, and tonsillitis. However, 60% of people with oropharyngeal infections are asymptomatic. In addition, many clinicians neglect to test for oropharyngeal gonorrhea because they do not screen for unprotected oral sex. Cure rates for this type of gonorrhea are much lower because of inadequate antibiotic concentrations in oral tissue. Other sites of uncomplicated local infection include the eyes, leading to conjunctivitis. This condition occurs almost exclusively in newborns born vaginally to infected mothers. Primary cutaneous infections also has been reported and is usually manifested as a localized ulcer of the genitalia, perineum, proximal lower extremities, and fingers. Complicated gonococcal infections include prostatitis, epididymitis, lymphangitis, and urethral stricture in men, and salpingitis, PID, and bartholinitis in women. Infections spread from the site of infection further into the genital tract, causing severe inflammation and scarring. In women, infections of the uterus, uterine tubes, and eventually the peritoneum is known as PID. The onset of PID symptoms may be rapid and usually occurs during menses. Women may experience chills, fever, nausea, vomiting, and lower abdominal pelvic pain that worsen with movement, such as walking, coughing, sneezing, and intercourse. Abdominal palpation often discloses bilateral lower quadrant tenderness and rebound tenderness from peritoneal irritation. Marked tenderness of the internal genitalia is often noted during pelvic exams. PID resulting from any pathogen contributes to infertility through a variety of mechanisms. During infection, the delicate ciliated epithelium of the uterine tubes is permanently damaged, and the lack of regular cilia movement can impair the transit of sperm and fertilized ova. Scarring and adhesion of the tubes may further impair fertility. Up to 18% of women who have been diagnosed with PID experience later infertility, and ectopic pregnancy rates in this population are as high as 9% because of slowed motility of the cilia in the fallopian tubes. Disseminated gonococcal infection, or DGI, is a rare systemic complication caused by the spread of infection through the bloodstream. Symptoms of this life-threatening condition include a generalized rash, severe joint pain, and even meningitis, and endocarditis. Gonococcal strains that can cause DGI may cause genital inflammation before systemic dissemination. If a mother has gonorrhea at the time of birth, she can transmit the infection to her child. Most states require that all infants receive prophylactic ophthalmic antibiotics to prevent gonococcal eye infection. Topical antibiotics may not be effective in eliminating neonatal infection, and systemic treatment is indicated for all newborns with known exposure. Untreated infections cause bilateral corneal ulceration with a profuse yellow or gray purulent exudate, and is followed by necrosis, scarring, and blindness. Newborns born to infected mothers also may develop gonorrheal rhinitis, anorectal infections, or an abscess at the site of electrode placement for fetal monitoring. Onset of symptoms generally occur 1 to 12 days after birth. So here's a picture of a gonococcal ophthalmia neonatorum. The evaluation and treatment. Because of the large percentage of infected women without symptoms, routine genital tract screening for at-risk women, Those younger than the age of 25, pregnant, or with new sexual partners is recommended. Men should be screened according to risk factors and symptoms. Clinical signs and symptoms are not sufficient for the differential diagnosis. The test that is used should be selected on the basis of the suspected site of infection. Nucleic acid hybridization tests can be used on samples collected from the vagina and urethra, as well as urine. Culture should be used to diagnose infections of the rectum or pharynx and conjunctiva of both sexes and all ages, as well as any site on boys. Microscopic evaluation of gram-stained slides of specimen from symptomatic men also can be used for diagnosis, and it is deemed positive for gonorrhea if gram-negative diplococci with typical kidney bean morphology are seen inside the polymorphonuclear leukocytes. Gonorrhea has developed resistance to many antibiotics and has the real potential to become resistant to all current treatments. There is currently only one CDC recommended drug, ceftriaxone, to treat gonorrhea, although less effective alternatives are available. To prevent further drug resistance, the CDC and the World Health Organization recommend a multi-drug treatment for gonorrhea that also is effective against chlamydia. The CDC is closely observing the drug resistance of gonorrhea through monitoring of samples obtained at clinics around the country. The CDC treatment guidelines are updated regularly, and the most recent edition found on the CDC website or app should be used. Current CDC treatment guidelines for uncomplicated gonorrhea infections are listed in the following box. Complicated infections require IV antibiotic therapy and possible hospitalization. So, for outpatient treatment for uncomplicated gonorrhea, infections of the cervix, urethra, rectum, and pharynx should include a single shot of ceftriaxone and azithromycin. Sexual partners also are assessed and treated according to these protocols, and sexual contact is avoided until treatment is completed. Condoms for all genital contact, including oral sex, are strongly recommended to prevent future infections. That brings us to syphilis. Syphilis, a disease with local and systemic manifestations that stretch over years, has been well known throughout history. Many famous figures from the ancient world and royal families were thought or known to have had syphilis. With the advent of the antibiotics and intensive public health efforts during and after World War II, the prevalence of syphilis declined sharply. Rates of syphilis reached a record low in 2000. However, since this all-time low, the rate of syphilis in the United States has doubled to 5.3 cases per 100,000. Men account for nearly 91% of all new cases of syphilis, whereas rates between sexes were equivalent 2 decades ago. Data suggest this increase is driven by transmission of syphilis among MSM and accounts for over 89% of new cases. Congenital syphilis, caused by vertical transmission of the spirochete, also has experienced resurgence in the US. After years of decline, the rate of congenital syphilis increased by 38% between 2012 and 2014 to 11.6 per 100,000. During pregnancy, untreated early syphilis results in perinatal death in as many as 40% of cases and may lead to perinatal complications in more than 70% of cases, because the spirochete can cross the placental membrane to infect the fetus. However, simple treatment with penicillin is 98% effective at preventing vertical transmission. Therefore, All pregnant women should be screened at their first prenatal visit, and women at risk should be screened again in their third trimester and at the time of delivery. So, what is the pathophysiology of syphilis? Treponema pallidum, the cause of syphilis, is an anaerobic spirochete bacterium that can grow in any human organ or tissue but cannot be cultured in vitro. When viewed through the dark field microscope, the treponema resembles a corkscrew with regular tight spirals and rotary motion. Because the bacterium is present in exudate from moist mucosal or cutaneous lesions, the spirochete is usually transmitted to others during the first few years of infection. Transmission generally occurs through minor abrasions during sexual intercourse, but can occur extragenitally as well. Although condoms can decrease the likelihood of infection, if lesions are present on areas not covered during intercourse, transmission can occur even with safer sex practices. The course of untreated syphilis consists of 4 stages based on clinical findings: primary, secondary, latent, and tertiary. The division between stages is not always apparent, and the drug of choice is the same for all stages. So here you're taking a look at the progression of untreated syphilis. So a good spot to hit pause just to kind of give yourself a review. Primary syphilis begins at the site of bacterial invasion, where T. pallidum multiplies in the epithelium and produces a granulomatous tissue reaction called Chancre. Some microorganisms drain with lymph into the adjacent lymph nodes, within the nodes, and at the site of Chancre, and cell-mediated and humoral immune responses are stimulated. So here you're taking a look at primary syphilis. Secondary syphilis is systemic during this stage. Blood-borne bacteria spread to all major organ systems. The secondary stage is followed by a period during which the immune system is able to suppress the infection, even without treatment. Spontaneous resolution of the skin lesion occurs and the individual enters the latent stage of the infection, leading us to latent syphilis. Latent syphilis may be subdivided into an early and late stages. However, no specific criteria delineate one from the other. Medical history and serologic studies can show that syphilis is present, but the individual has no clinical manifestations. Transmission remains possible during this phase. Tertiary syphilis is the most severe stage, involving significant morbidity and mortality. The pathogenesis of the syphilitic manifestations at this stage remain unclear. The destructive skin, bone, and soft tissue lesions of tertiary syphilis probably are caused by a severe hypersensitivity reaction to the microorganism. Within the cardiovascular system, infection with the T. pallidum may cause aneurysms, heart valve insufficiencies, and heart failure. Congenital syphilis is caused by vertical transmission and is estimated to cause 500,000 fetal and neonatal deaths every year worldwide. Syphilis becomes a systemic disease shortly after maternal infection and can be transmitted to the fetus as early as the 9th week of gestation because the spirochete can pass through the placenta. Intrauterine infection causes fetal or perinatal death in 40% of affected infants, and many live-born infants have permanent, lifelong morbidity, including congenital abnormalities. The risk of congenital syphilis is estimated up to 80% in primary syphilis and declines with advancing stages of the disease. Penicillin is very effective in decreasing morbidity and mortality, if the disease can be diagnosed early in fetal development. So, clinical manifestations in the primary stage. In adults, the incubation period of syphilis ranges anywhere from 12 days to 12 weeks after exposure and averages around 3 weeks. A sore or hard chancery develops at the site of treponema entry. Typically, the chancery is an eroded, painless, firm, and indurated hard ulcer that's up to 2 centimeters in diameter. It is firm, enlarged, and non-tender regional lymph node accompanying chanceries. Typical chanceries of the penis and vulva are shown in the figure 27.5. Syphilitic chanceries are not always typical, and syphilis should be considered in the presence of any open lesion. Secondary infection can cause chanceries to become necrotic and painful, and lesions on the fingers may be dry, scaly, and papular, or moist and vegetative. If left untreated, the chancery of primary syphilis heals in 2 to 8 weeks, and then spontaneously disappears, usually without leaving a scar. That leads us to the secondary stage. Clinical manifestations of secondary syphilis usually develop at 6 weeks after the first appearance of the chancery, but may overlap with those of the primary stage. Systemic symptoms are variable and can include low-grade fever, malaise, sore throat, hoarseness, anorexia, generalized adenopathy, headache, joint pain, and skin or mucous membrane lesions or rashes. Cutaneous rashes are generally papulosquamous, but any variation or combination of muscular, papular, and pustular lesions may be seen. Lesions are often widespread and bilateral, appearing on the palms and soles. Some lesions become hypertrophied, flat, moist, and wart-like, or vegetative. These lesions, called condylomata, are highly contagious and develop on the perineum, vulva, and groin of women, and around the inner thigh and anal area in men and women. Besides skin sores, oral mucous membrane lesions, lymphadenopathy, pruritus, and alopecia are common. Some individuals develop anemia, leukocytosis, increased sedimentation rate, hepatitis, transitory proteinuria, arthritis, electrocardiographic abnormalities, and central nervous system symptoms. Regardless of treatment, cutaneous lesions generally heal in 2 to 10 weeks. Within the CNS, the presence of T. pallidum in cerebrospinal fluid may cause the manifestations of neurosyphilis, including altered mental status and meningitis, which can occur within any stage of syphilis infection, but are more common in early stages of infection. So here you're taking a look at secondary syphilis. And here you see the Condylomata lata. Latent and tertiary stages. The asymptomatic latent stage of syphilis may be as short as 1 year or as long as a lifetime. After the latent stage, tertiary syphilis may present with gumus, cardiovascular lesions, and neurosyphilis manifestations, including tabes dorsalis and general paresis. Jesus Christ, let's start that over again. Let's take that whole minute out. Latent and tertiary stages. The symptomatic, oh my God. Latent and tertiary stages. The asymptomatic, latent stage of syphilis may be as short as 1 year or as long as a lifetime. After the latent stage, Tertiary syphilis may present with gumus, cardiovascular lesions, and neurosyphilis manifestations, including tabes dorsalis and general paresis. Tertiary syphilis is rare because of the widespread availability of antibiotics. Congenital syphilis. Congenital syphilis is caused by the passage of the spirochete across the placental membrane to affect any or all fetal tissues. The infection can cause fetal death or growth abnormalities, including changes in the fetal bones, teeth, and neurologic system. Affected newborns can have a variety of manifestations of the disease, including growth abnormalities, rashes, hepatosplenomegaly, jaundice, and CNS involvement, including blindness and deafness. A classical reported late manifestation of congenital syphilis is notched incisors. While now rare, this stigma is used in historical studies of syphilis. So, what is our evaluation and treatment for syphilis? Numerous dermatologic disorders can mimic the skin lesion of secondary syphilis, making differential diagnosis difficult. Laboratory confirmation is important. Two categories of serologic testing exist: non-treponemal antigen tests and treponemal antibody tests. Non-treponemal antigen tests, which demonstrate the presence of reagin in serum, provide indirect evidence of infection. Examples of non-treponemal analysis are the Venereal Disease Research Laboratory antigen and rapid plasma reagin tests. These tests yield a positive result in more than 50% of individuals with primary syphilis and in 100% of individuals in the secondary phase of the disease, and can be useful in screening and assessing response to treatment. So there is this box here regarding false positive serologic tests for syphilis. Um, doesn't hurt to review that just to get an idea what could trigger a false positive. And again, I'm stopping at certain spots so you can hit pause. Because the VDRL and RPR tests have high rates of false positives, a treponemal test is performed if the screening test is positive. Treponemal tests are serologic specific tests that are used to assess antibody response to T. pallidum and include enzyme immunoassays. Chemoluminescence immunoassays, the fluorescent treponemal antibody absorption tests, and the passive particle agglutination assay. Preferred treatment for all stages of syphilis is perinatal injection of benzathicine penicillin G, because other types of penicillin are not as effective. If the individual has manifested signs of the disease for less than 1 year, a single intramuscular dose is appropriate. If signs have been present for more than 1 year, or they are asymptomatic and assumed to be in the latent syphilis, the treatment is 3-week injections. The CDC is the best source of current information on treatment regimens. Penicillin therapy also is appropriate for pregnant women to prevent vertical transmission. There is no evidence to date that T. pallidum has developed resistance to penicillin. In fact, it is highly sensitive, but because of the slow replication time, serum levels must be maintained for 7 to 14 days. Men and non-pregnant women who are allergic to penicillin may receive oral doxycycline, 100 milligrams twice daily for 14 days, or tetracycline, 500 milligrams every day for 14 days. Pregnant women with a penicillin allergy should be desensitized and then treated with a benzathine penicillin G, as recommended by the CDC, because of other available antibiotics cause lifelong discoloration of the forming teeth in the fetus. Repeated assessment of the VDRL and RPR titer is used to determine effectiveness of treatment. Titers should decrease fourfold if treatment was successful. Sexual partners also are tested and treated, and the use of condoms is recommended until effective treatment is verified. Newborns of mothers with documented syphilis need careful evaluation after birth. Definitive diagnosis of congenital syphilis is complicated by the presence of maternal antibodies in the newborn's blood. Treatment decisions are made based on maternal status, clinical symptoms of congenital syphilis, and also comparison of maternal and neonatal titers. If the infant requires treatment, penicillin is the drug of choice, with careful titration, dosing depending on the fetal weight and the day of treatment. And the CDC is the best source of current information. That brings us to Chancroid. Chancroid, or soft chancre, is an acute infectious disease that was first differentiated from syphilis in 1852. It is caused by the Haemophilus ducreyi, a gram-negative bacillus. The incidence of chancroid is decreasing worldwide, and it is infrequently seen in the US. Sporadic outbreaks occur throughout the world and tend to be associated with prostitution and illicit drug use. When individuals continue to engage in intercourse in spite of painful genital lesions, chancroid is a risk factor for HIV acquisition, and existing HIV infection is a risk factor for chancroid infection with exposure. So its pathophysiology. H. ducreyi is a gram-negative bacillus with rounded ends. It is commonly observed in small chains or clusters along mucous strands under a microscope. Transmission can occur through sexual contact and auto-inoculation, but there is no evidence for vertical transmission. Chancroid lesions are found throughout the genital area. Initially, the papule enlarges. It then erodes into a soft, circumscribed ulcer containing a superficial exudate of varying size and presentation. Beneath the ulcer is a lesion characterized by edema, endothelial proliferation, and a base of granulation tissue. Adjacent lymph nodes are acutely inflamed and full of polymorphonuclear leukocytes and necrotic cells. So what kind of clinical manifestations do we see? Chancroid has an incubation period of 3 to 10 days. Women are generally asymptomatic, but depending on the site of infection, can present with less obvious symptoms. Constitutional symptoms are unusual. An initial vesicopostural lesion forms at the site of inoculation and erodes into a soft ulcer with a necrotic base, surrounding erythema and a ragged, serpiginous border. Unilateral painful local lymphadenopathy presents in about half of infected individuals. Inguinal buboes develop in 7 to 10 days after initial chancre and fill with exudate. In 25 to 60% of cases, the buboes spontaneously rupture out onto the skin, spreading the infection through auto-inoculation. So here we're taking a look at chancroid. Ulcers on the prepuce may lead to phimosis or paraphimosis. Other complications of chancroid include balanitis, secondary infections, necrosis, and fistula formation. Lesions may take months or years to heal and cause scarring. So our evaluation and treatment, therefore. Chancroid is easily confused with other types of genital ulcers, particularly those of syphilis, genital herpes, and granuloma inguinale. Unlike the syphilitic ulcer, chancroidal ulcer is painful, tender, and non-indurated, and inguinal lymphadenopathy is pronounced. Microscopic analysis of the gram-stained smear from the chancroid helps to identify the microorganism. Definitive diagnosis depends on recovery of H. ducreyi from cultured specimens. However, the culture medium is not commercially available. Diagnosis depends on the clinical presentation of a painful genital ulcer, with inguinal lymphadenopathy with negative testing for syphilis and herpes simplex virus. In addition, HIV testing is recommended because chancroid is a cofactor for transmission of HIV. Resistance to recommended antibiotics has emerged in isolated instances worldwide. Recent treatment recommendations include a single intramuscular injection of ceftriaxone or a single dose of oral azithromycin. Effective oral multiple dose regimens include ciprofloxacin orally twice daily for 3 days, or erythromycin 3 times daily for 7 days. Persons infected with HIV and uncircumcised men have higher rates of treatment failure and may require a longer treatment regimen. Treatment failure requires more intensive assessment for co-infection with other diseases. Simultaneous treatment of sexual partners and use of condoms are recommended to prevent reinfection. That brings us to the granuloma inguinale. Granuloma inguinale, also known as donovanosis, is a chronic, progressively destructive bacterial infection caused by Klebsiella granulomatis. Although sexually transmitted, granuloma inguinale has a low transmission rate between sexual partners. Infection through fecal contamination and autoinoculation also is possible. As with all genital ulcerative diseases, granuloma inguinale plays a role in HIV transmission. Granuloma inguinale very rarely occurs in the US. It is more prevalent in some tropical and subtropical parts of the world, such as India, New Guinea, Africa, Central Australia, and to the lesser extent the Caribbean and Brazil. So what is its pathophysiology? C. granulomatous is a gram-negative, non-sporing, non-motile, encapsulated rod not easily cultured in the lab. After an individual is infected, bacteria survive and multiply within vacuoles of large histiocytic cells or polymorphonucleic leukocytes. The bacteria reproduce within these cells, and a vacuole may contain 20 to 30 microorganisms. These bacteria-filled vacuoles were identified by Donovan in 1905 and were termed Donovan bodies. The presence of Donovan bodies in tissue smears of material from lesions is considered ideal for diagnosis, but this test is difficult even in well-equipped labs. The incubation period of granuloma inguinale is 8 to 80 days. As lesions begin to form, single lesions often coalesce with nearby lesions or form new lesions by autoinoculation of nearby skin surfaces. Progression from the initial nodule to a large granuloma heaped ulcer occurs slowly. These lesions are vascularized and bleed easily. Secondary infection may occur, increasing tissue damage and residual scarring. The disease may spread to the bones, joints, and liver. So, clinical manifestations. The primary sites for development of the lesion are the distal penis in men and the introitus in women. The initial lesion is an indurated, sharply defined, painless, subcutaneous nodule that is often preceded and accompanied by itching. Nodules bleed easily and contain abundant red, beefy-looking granulation tissue. These lesions spread as the disease progresses. Secondary infection may occur, increasing tissue damage and residual scarring. Although systemic symptoms are rare, the disease may spread to the bones, joints, and liver. In some cases, infection spreads to the inguinal area of the area and produces pseudo buboes. In these instances, the affected lymph nodes are not directly affected, but the surrounding area may be infected and abscessed. So, its evaluation and treatment. Although the clinical manifestations of this disease are important for diagnosis, confirmation involves microscopic examination for Donovan bodies in a smear or biopsy specimen. Currently, there is not an FDA-approved laboratory test for detection of K. granulomatis. Many antibiotics successfully treat K. granulomatis. With effective antibiotic treatment, lesions begin to heal in 7 days, but treatment is continued for at least 3 weeks and until all lesions are healed. Oral therapy includes doxycycline, 100 milligrams twice a day, azithromycin 1 gram once a week for 3 weeks, and until lesions are healed, ciprofloxacin 750 milligrams twice a day for at least 3 weeks, erythromycin base 500 milligrams 4 times a day for at least 3 weeks, or trimethoprim sulfamethoxazole 160 milligrams slash 800 milligrams double strength tablet twice a day for at least 3 weeks. Relapses can occur 6 to 18 months later despite effective initial therapy. Thus, prolonged follow-up is necessary, as is treatment of sexual partners. Because the STI frequently coexist, individuals should be tested for chlamydia, gonorrhea, syphilis, hepatitis B, and HIV. Which brings us to the bacterial vaginosis. Bacterial vaginosis, or BV, previously known as vaginitis, nonspecific vaginosis, Haemophilus, Corneobacterium or Gardnerella vaginitis, is a sexually associated condition, but is not necessarily considered an STI. The condition is associated with sexual contact, including genital touching and digital penetration, oral sex, and penile penetration. Although bacterial vaginosis occurs mostly in sexually active women of reproductive age, it can affect women, especially menopausal women, who are not sexually active. BV is diagnosed by the presence of characteristic symptoms and clinical findings. Prevalence rates vary from 17% among women in family planning clinics to 37% among some groups of pregnant women. 50% of women clinically diagnosed with BV state they are asymptomatic. So, what is its pathophysiology? The exact etiology of BV is unknown, but is thought to be a dysbiosis of normal vaginal flora that is associated with sexual contact. Gardnerella vaginalis and various anaerobics, including Mycoplasma hominis, Bacteroides, and Meibelinococcus, interact and proliferate when lactobacilli are decreased or absent. Bacteria adhere to vaginal epithelium and form a scaffolding-like biofilm to which other bacteria can adhere, facilitating their proliferation and causing a non-inflammatory response in the surrounding tissues. As the vaginal microbiome changes, the catabolic enzymes degrade proteins into amines. In turn, amines elevate the vaginal pH and produce the characteristic fishy odor associated with BV. BV has been implicated in PID, chorioamnionitis, preterm labor, and postpartum endometritis. In addition, BV increases a woman's risk of contracting other STIs, such as HIV. So, what kind of clinical manifestations do we see? BV is characterized by a thin, gray, homogeneous, and malodorous discharge that adheres to the vaginal walls, but is often copious enough to drain from the vagina. Occasionally, the discharge is bubbly or frothy. The vaginal pH is usually 5 to 5.5, and women often complain of a strong, foul, fishy vaginal odor, particularly after intercourse or during menses. Odor is intensified by contact with alkaline secretions, including semen and menstrual discharge. Male and female partners of infected women may harbor the microorganism responsible for BV and have no signs or symptoms. So, our evaluation and treatment, therefore, diagnosis of BV can be made on the basis of the presence of three of the following four criteria, known as the AMSEL criteria. The first being the presence of homogeneous adherent gray or white vaginal discharge. 2. A vaginal pH that is greater than 4.5. The third being a positive amine odor in the presence of alkali, such as potassium hydroxide, known as the whiff test. And 4. The presence of clue cells on a wet mount. Clue cells are considered pathogenomic for BV. They are vaginal epithelial cells that are covered with bacteria, causing them to look as if they were sprinkled with pepper. The saline wet mount also may show the absence of lactobacilli and few or no leukocytes. There also is commercially available tests. Affirm, the VPIII, that uses DNA hybridization to detect G. vaginalis. Cultures for BV are not recommended. However, high-risk individuals should be screened for gonorrhea and chlamydia. The most common used treatment for BV is a course of oral flagyl, 500 milligrams twice daily for 7 days. 0.75% vaginal gel, once daily for 5 days, or clindamycin cream, 2% applied vaginally for 7 days. Alternative regimens include tinidazole, 2 grams orally once daily for 2 days, or 1 gram orally for 5 days. Oral clindamycin, 300 milligrams, twice daily for 7 days, or clindamycin ovules, 100 milligrams, intravaginally for 7 days. Treatment for BV should be personalized based on the woman's needs and behaviors. For example, euflagyl and tinidazole strongly react with alcohol and should not be used by women who cannot or will not eliminate alcohol ingestion for the full duration of the treatment, plus an additional 24 hours. In addition, the ovules may weaken latex condoms and diaphragms. BV treatment in women infected with HIV is the same as that in individuals who are HIV negative. The CDC currently recommends treatment of BV in pregnancy to reduce the risk of poor perinatal outcomes, including a preterm birth. This brings us to chlamydia. Chlamydia is the most common name for infections caused by Chlamydia trachomatis. C. trachomatis is responsible for a variety of syndromes, including acute urethral syndrome, non-gonococcal urethritis, mucopurulent cervicitis, and PID. Chlamydia is the most common reportable STI in the US and is the leading cause of preventable infertility and ectopic pregnancy. In 2014, more than 1.4 million cases of chlamydial infections were reported, the greatest number of cases ever reported in a single year. Rates of chlamydia infection are increasing in all age groups, areas of the country, and racial ethnic groups. This increase probably reflects the continued expansion of screening efforts and the increased use of more sensitive diagnostic tests, as well as an actual increase in incidence. The majority of reported cases of chlamydia are in people younger than 26 years of age, but the incidence in older adults is increasing. Up to 90% of women with chlamydia infections are asymptomatic. which can delay diagnosis and increase the risk of long-term health sequelae. Without timely treatment, 10 to 20% of women will have infections spread to the uterus and uterine tubes. Risk groups for chlamydia include age younger than 26, recent new sexual partner, and drug use or other risky behavior. Like gonorrhea, chlamydia infection can be transmitted from mother to infant during birth and can cause eye infections and pneumonia in affected newborns. So, what is its pathophysiology? C. trachomatis is an obligate gram-negative intracellular bacterium that lacks the ability to reproduce without a host cell. It is differentiated from other bacteria by its unique two-part growth cycle. The first part consists of an elementary body that is small and resilient and is able to survive extracellularly. Once the elementary body attaches itself to a receptor host cell, it is able to enter the endocytosis. Once inside the cell, the second part of the cycle begins, and the microorganism becomes a metabolically active parasite, reproducing within the cell until the cell is destroyed and ruptures, disseminating up to 1,000 new elementary bodies. Infection with C. trachomatis produces an inflammatory reaction that results in permanent scarring of tissues. Chlamydia microorganisms are always pathogens. They are not part of the normal flora of the urogenital tract, despite the fact that infection is often asymptomatic. Numerous serotypes or strains of C. trachomatis have been identified. Some cause urogenital infection, some blindness, and others lymphogranuloma venereum, which is discussed in the next section. The strains of C. trachomatis that cause urogenital infection require squamous columnar or columnar epithelial cells as hosts. C. trachomatis infects and disrupts superficial tissues, causing damage and scarring, but does not seem to invade or destroy deeper tissues. In newborns, several sites may be inoculated with chlamydia during passage through the infected maternal cervix. Those include the eyes, nasopharynx, rectum, and vagina. The infant also may aspirate infected secretions with its first breaths, resulting in a chlamydial pneumonitis and substantial newborn morbidity. So, clinical manifestations. Chlamydial infections are asymptomatic in up to 90% of adults. Urogenital infections caused by chlamydia closely parallel those caused by gonorrhea. Both microorganisms infect superficial genital tract tissue, such as the mucosa of the urethra and cervix, and both can invade the epididymitis, the fallopian tubes, and, rarely, the hepatic capsule. The following table lists the pathophysiologic similarities of chlamydial and gonococcal infections. Men and women have different responses to the infection. So again, here's a good spot to hit pause so you can see the difference between your gonorrhea and your chlamydia. The rate of chlamydial infection in men appears to be rising, with 22% increase in diagnosis from 2010 to 2014. This increase may be an expression of increased testing as a result of easier screening methods. Rates of diagnosis are highest in adolescent men who have sex with women. Although most men do not have symptoms, even while contagious, chlamydial infection can cause non-gonococcal urethritis. Clinically, urethritis caused by gonorrhea and chlamydia cannot be differentiated. Both have a 7 to 21-day incubation period and cause dysuria. Although urethral discharge in men may be similar in the two infections, chlamydial discharge tends to be more clear, and gonococcal discharge more purulent. Men might note a clear mucus discharge or mild burning with urination. Chlamydial epididymitis can accompany urethritis in men and is characterized by fever and a unilateral painful swollen scrotum. Chlamydial infection also causes proctitis in people who have receptive anal intercourse. Chlamydial proctitis is generally mild, although it may, like gonorrheal proctitis, cause rectal bleeding, mucus discharge, and diarrhea. Reiter syndrome is also associated with untreated urogenital tract infections. C. trachomatis can cause asymptomatic urethral infection or acute urethral syndrome in infected women. Chlamydial infection of Bartholin greater vestibular glands can cause purulent discharge, leading to a Bartholin cyst. Women with chlamydial cervicitis may be asymptomatic or may have a yellow mucopurulent discharge from the cervical os and a hypertrophic edematous and friable area of cervical ectomy. The women also may report intermenstrual or postcoital spotting. Although ectopy alone cannot indicate a pathologic condition, an erythematous, raw, and friable cervix is suggestive of a chlamydial cervicitis. So here you're taking a look at chlamydial cervicitis, the beefy red mucosa. Chlamydial infection is the leading cause of tubal infertility in women because of infectious damage to the fallopian tubes, similar to that which may occur with gonorrhea. Risk factors for infertility include the duration and severity of infection and the lifetime number of chlamydial infections. Even women with asymptomatic salpingitis have a risk of subsequent infertility. The most common manifestation of chlamydial infection in the newborn are conjunctivitis and pneumonia. Prophylactic treatment with antibiotic ointment at birth does not provide complete protection against neonatal conjunctivitis and does not protect against neonatal pneumonia. IV antibiotics are needed for any child at risk of acquisition. Chlamydial conjunctivitis begins between 5 and 14 days after delivery, when the infant's eyes begin to water. The discharge may become purulent, and both eyes may become red and swollen. Scarring of the conjunctiva may result, but the infection does not cause blindness. Infants with chlamydial pneumonia develop staccato coughing spells, nasal congestion, and fever at 3 to 11 weeks of age. So how do we evaluate and treat chlamydia? Since most infections are asymptomatic, the CDC recommends widespread screening of at-risk groups. The complete detailing of groups needing annual screening can be found in their treatment guideline on their website or through the smartphone app. All sexually active women who are less than 26 years of age should be screened annually. In addition, the CDC recommends that all women, regardless of age, be screened if they have a new sexual partner or their partner is not monogamous. Pregnant women should be routinely screened for chlamydia at least once during their pregnancy. Methods for diagnosing chlamydial infections include tissue culture, direct chlamydial enzyme immunoassays, fluorescent-labeled monoclonal antibody tests, and nucleic acid amplification tests. Currently, tests using chlamydial-specific nucleic acid sequences are the most sensitive and cost-effective tests available. In addition, they are easy to use with a variety of specimen types. Concurrent testing for gonorrhea can be done using the same swab. Your NAAT can be performed on samples taken from the vagina, endocervix, or urethra, or urine specimens can be used. The person should be tested in all locations of genital contact. The ease of NAAT testing means that screening can be performed without a clinician, if needed, because the individual can collect the specimen following basic instructions. Your C. trachomatis is susceptible to inexpensive, readily accessible antibiotics, and treatment should begin as soon as possible to prevent complications. Treatment includes antibiotic therapy for infected individuals and all sexual contacts. Abstinence or use of condoms during treatment for the 7 days after treatment is recommended. The CDC also recommends observed on-site treatment for both partners when feasible. Azithromycin is given 1 gram orally as a single dose or a 7-day course of oral doxycycline can be administered 100 milligrams twice daily. Single-dose azithromycin is preferred if adherence to a multiple-dose, multiple-day regimen is not feasible for the individual. Alternative regimens include a 7-day course of oral erythromycin, 500 milligrams 4 times a day, or erythromycin E, 800 milligrams 4 times daily for 7 days, ofloxacin, 300 milligrams twice daily, and levofloxacin, 500 milligrams once daily for 7 days. Also are effective alternatives. Azithromycin is the drug of choice in pregnancy. A test of cure is only needed if there is a concern that treatment of both partners was not successful. However, treatment failures are common, especially in multi-dose regimens, and when the partner is not immediately provided with a prescription. Your lymphogranuloma venereum, your C. trachomatis, invasive serovirus of strains L1, 2, and 3 can cause a chronic STI known as lymphogranuloma venereum, or LGV, which may be confused with syphilis, herpes, and/or Chancroid. LGV was previously rare in the developing world, but now is increasingly found in men who have sex with men and may spread to other populations. The infection is acquired during sexual intercourse or through contact with contaminated exudate from active lesions. HIV infection increases the likelihood of acquisition and the severity of symptoms. So its pathophysiology. The strain of C. trachomatis that causes LGV probably penetrates skin and mucous membranes through tiny abrasions. LGV spreads to genital and rectal lymphatic tissue, where it causes marked inflammation, necrosis, buboes, abscesses of inguinal lymph nodes, and infection of surrounding tissue. Healing occurs by fibrosis after several weeks or months and result in scarring and damaging the lymph nodes and disrupting their function. LGV can cause permanent lymphatic disruption and genital disfigurement. Affected nodes become chronically swollen, hardened, and enlarged. C. trachomatis also spreads systemically through the bloodstream and can enter the CNS. So, clinical manifestations. The primary lesion of LGV appears after an incubation period of 5 to 21 days. The lesion is most commonly a herpetiform ulcer, but it can assume various forms. The ulcer generally is asymptomatic and inconspicuous and heals rapidly, leaving no scar. However, when contracted through receptive anal intercourse, the ulcer is never visible. When rectal infections occur, LGV can cause an inflammatory response that mimics inflammatory bowel disease or proctocolitis. Other signs of primary LGV include a large, tender lymphatic nodule or bubo, urethritis, and cervicitis. While historically this infection resulted in 3 clinical stages, anorectal infection has become the most common location of infection and results as symptoms that mimic other primary care conditions. Clinical symptoms of anorectal infection mimic other inflammatory bowel conditions and include irregular bowel movements, multiple ulcerations of the rectal mucosa, mucopurulent rectal discharge, and rectovaginal fistulae in women. Individuals may have fever, rectal pain, and tenesmus. Rectal strictures, perirectal abscesses, and anal fissures may develop with untreated infection. So its evaluation and treatment, clinical manifestations, history of sexual intercourse, and laboratory tests are used for LGV diagnosis. LGV is diagnosed with a NAAT testing at the suspected site of infection. If clinical symptoms match LGV presentation, pharmacologic treatment should begin while waiting definitive diagnosis with test results. LGV is treated with oral doxycycline 100 mg twice daily for 21 days. A 21-day course of erythromycin 500 mg is also effective. Sexual partners with the past 60 days should be treated. Which brings us to our viral infections. Genital herpes. Genital herpes, which causes painful blisters, cold sores, is the most common infectious cause of genital ulceration in the United States. In fact, genital infection with herpes simplex virus is an epidemic in the United States. HSV is not a reportable disease, so national statistics are not available. However, HSV infections are estimated to affect 1 million new individuals each year. Recurrent infections are mostly asymptomatic and affect an estimated 50 million Americans annually. 80% of infected individuals do not know they have herpes. Genital herpes can be caused by either of the two serotypes of HSV, type 1 or type 2. Historically, type 1 lesions were more common around the mouth, while type 2 lesions were more frequently found in the genital area. However, HSV1 is increasingly found in the anogenital area. HSV2 outbreaks are more frequent and more severe. So serologic testing to determine the HSV subtype is warranted at diagnosis to guide suppression efforts. HSV infection is transmitted through contact with HSV-infected fluids or skin, as occurs with genital skin or mucosal contact with a person shedding the virus. There is even the possibility that saliva alone can transmit the virus when placed on mucous membranes or genitals for lubrication. Persons without symptoms probably transmit most infections. Asymptomatic viral shedding is common. Transmission rates are not well identified. However, women and men who are the receptive partner for men are more susceptible to contracting herpes related to prolonged semen contact with the vaginal or rectal mucosa. Any type of rough intercourse that causes break in the skin surface increases transmission as well. It is estimated that a woman has an 80% to 90% risk of developing genital herpes after being exposed to an infected man. Condoms reduce the risk of transmission, especially from males to females. However, if lesions or shedding occurs outside the area covered by the condom, transmission can still occur. Female condoms offer a bit more protection from HSV because they cover and protect the vulva, but they do not eliminate the risk entirely. HSV infection greatly increases the risk of HIV acquisition. People with HSV are 4 times more likely to contract HIV if exposed, potentially because of skin splits that occur as a result of HSV infection. Neonatal infections can begin in utero, or more commonly during the intrapartum or postpartum period. The risk of transmission of HSV to neonates varies from less than 1% among women with recurrence of known herpes at term to up to 30 to 50% in women who acquire HSV near term. Perinatal transmission can cause extensive morbidity and mortality. Intrauterine transmission is rare, only 5% of neonatal infections, but can occur through the transplantal or ascending infection and can cause fetal malformation. 85% of infections are transmitted during the intrapartum period. Infants are at greatest risk if the mother has primary infection acquired near the time of delivery, rather than a recurrent infection or infection acquired during the first half of the pregnancy. Ruptured membranes have a role in the development of HSV. Rupture of membrane for more than 4 hours increases the risk of the fetus for contracting HSV. Internal fetal monitoring devices also increase the risk of vertical transmission because they break the fetal skin. Infants also may be exposed after birth from mouth to mouth kissing by family members. There have been several cases of infants exposed during ritual circumcision involving direct urogenital suction. So, the pathophysiology. After initial exposure and entry of the virus at mucocutaneous sites or abraded skin, the virus undergoes replication locally in the dermis and epidermis. This leads to cell destruction, transudation, and vesicle formation. The virus spreads to contiguous cells and eventually into sensory nerves. This process often causes a systemic inflammatory immune response, especially with HSV2 infection that includes fever and malaise. In rare cases, the herpes can cause CNS manifestations, painful lesions that can last from days to weeks. Eventually, the virus is transported intraaxonally to the dorsal root, where it remains in a latent stage until it becomes reactivated. After oral infection, the latent virus resides in the trigeminal ganglion. After genital infection, it resides in the dorsal sacral nerve roots. During the latent period, the viral genome is maintained in the host cell nucleus without causing cell death. Latent infections become reactivated, often during times of physical or emotional stress, and cause a recurrent infection. Compared to HSV1 infections, reactivation of HSV2 infection is twice as common, and the likelihood of HSV2 recurrent infection is 8 to 10 times that of HSV1. Reactivation of HSV is not well understood, but may be attributable to physical, hormonal, and immunologic stimuli. During the reactivation, the viral genomes that are transported through the peripheral senses or sensory nerves back to the dermal surface. Shedding of the virus occurs during outbreaks and also may occur when the person is asymptomatic, increasing the likelihood of transmission. Antiviral medications decrease asymptomatic viral shedding and should be considered as an adjunct to safe sex practices. So, clinical manifestations. Three distinct syndromes associated with HSV infection are first episode primary genital infection, first episode non-primary HSV, and recurrent infections. The manifestations of each one depend on the individual's immune state. First episode primary genital infection occurs when an individual has no antibodies to HSV1 or HSV2. Many primary infections with HSV are asymptomatic, or the symptoms are not severe enough to warrant medical attention. If symptoms occur, the individual may have small 1 to 2 millimeter multiple vesicular lesions at the site of infection, usually on the labia minora, fourchette, penis, or mouth. They also may appear on the cervix, buttocks, and inner thigh, and are often painful and pruritic. These lesions usually last about 10 to 20 days. The lesions of HSV1 and 2 can be very small and almost indistinguishable to the naked eye or fairly large and clustered into raw areas. These wet lesions actively shed virus for about 10 to 14 days, after which they heal by reepithelialization. Small lesions may coalesce into larger ulcers and become secondarily infected. So here you're taking a look at the different types of herpes lesions. Systemic manifestations often accompany primary HSV infection, and an individual may experience fever, malaise, myalgia, lymphadenopathy, and urinary retention. Pharyngitis, aseptic meningitis, and hepatitis also may accompany primary HSV infection. The following figure illustrates the clinical course of primary genital HSV. So here you see the Duration of viral shedding. The first episode, non-primary HSV, occurs in individuals who have pre-existing antibodies. In some individuals, the primary infection may not have any clinical manifestations, but the HSV virus has become latent in the nerve root and can reactivate later in life. Compared with primary infection, the first episode of non-primary HSV is often milder, with fewer lesions that are less painful and heal faster. Fewer systemic manifestations occur, and viral shedding is of shorter duration. However, the symptoms may be severe if the second infection occurs during a period of immunocompromised health status. Recurrent infections usually produce mild local symptoms. The number of lesions is greatly reduced, and the lesions are less painful. Lesions are often unilateral with crusting within 4 to 5 days. Recovery and healing are usually complete within 10 days. Asymptomatic viral shedding can occur with both HSV1 and HSV2, but is more common with HSV2. Individuals infected with HSV2 are more likely to experience recurrent infections. Recurrent infections occur on an average of 5 to 8 times per year, but may be more frequent in the first few years of life of infection. Individuals may experience prodromal symptoms a few hours to 2 days before the eruption of lesions. Women may experience a vaginal discharge and dysuria, and 44% of men have dysuria. Symptomatic HSV infection of the newborn may occur any time in the first month of life. Manifestations range from a local infection of the eyes, skin, or mucous membranes to a severe disseminating infection with CNS involvement. About 70% of affected infants present with skin lesions. CNS involvement includes seizures and is associated with a mortality of more than 50% and extensive neurologic sequelae in survivors. That leads us to our evaluation and treatment. Genital HSV infection is suggested if typical genital lesions are present. Painful genital lesions alone are enough to begin treatment. The CDC recommends serologic testing for diagnosis and to determine the virus subtype, because the prognosis and risk of transmission differ. Viral cultures have been used in the past, but their sensitivity is low, especially if lesions have crusted over and have begun healing. There is no cure for HSV, only symptom management and viral suppression treatment. All primary outbreaks should be treated with antiviral medications to prevent complications and speed healing. Oral acyclovir, valacyclovir, penciclovir, and famciclovir are all used for primary and periodic outbreaks and to prevent recurrences. Acyclovir has a better safety profile for pregnant and nursing women, but there is ongoing research supporting the safety of valciclovir as well. IV acyclovir is reserved for very ill or severely immunocompromised individuals. Suppressive treatment is recommended for individuals with frequent or severe outbreaks, and pregnant women at term with a history of herpes. Suppressive treatment also may reduce asymptomatic viral shedding, decreasing transmission to sexual partners and vaginally born infants. Although there are few side effects with suppression drugs, the decision to take daily medication is complex for many individuals. Although male and female condoms offer some protection, individuals with HSV should refrain from all genital or oral contact when prodromal or symptomatic and understand that the undetermined risk of transmission exists even during asymptomatic periods. That leads us to HPV, also known as the human papillomavirus infection. Human papillomavirus infection is the most common symptomatic viral STI in the United States. Although more than 5.5 million cases are diagnosed yearly, the prevalence is considered underestimated because HPV infection is often subclinical. More sensitive measures of HPV indicate that 50% of all sexually active people are infected with the virus at some point in their lives, although these numbers are expected to decrease sharply in response to widespread vaccination. The virus is easily transmitted through direct contact with lesions or infected secretions. Vertical transmission in utero and during vaginal birth is also possible. More than 120 different types of HPV have been identified. More than 40 serotypes are unique to the stratified squamous epithelia of the anogenital area, although research is finding these same subtypes also may infect the oropharynx. These are divided into high-risk serotypes and low-risk serotypes. Serotypes 6 and 11 are associated with 90% of genital warts. These low-risk or non-oncogenic subtypes can coexist with the high-risk types, but do not cause cancer independently. Genital warts are very contagious, with transmission rates among individuals estimated to be between 38 and 95%. Such a wide range is attributable to the subclinical nature of some infections and various influencing factors that include number of exposures, HPV type, location of lesion, and cellular immunity response. High risk or oncogenic type 16 and 18 are the most common, causing up to 70% of anogenital cancers and are associated highly with oropharyngeal cancers that are discussed in chapter 12, 13, and 25. HPV-related cancers of the anogenital and oropharynx areas are more common than ovarian cancer in women and more common than brain cancer in men. In future generations, most of these cancers can be prevented through vaccination before HPV exposure. HPV infection is closely associated with multiple sexual partners and early onset of sexual activity, and is most common in teens and young adults, 16 to 25 years of age. Fortunately, most cases of HPV are transient, and 70% of healthy individuals will spontaneously eliminate the virus. The persistence of the virus and the immune response play a role in the development of cancer following HPV exposure. Behaviors and conditions that affect overall health status affect the body's ability to clear HPV infection. Alcohol use, smoking, and HIV infection are strongly correlated with persistent HPV infection. Several vaccines are available to protect against HPV. All approved vaccines use non-infectious virus-like particles to induce an immune response, and newer vaccines protect against a greater number of subtypes. Approved vaccine induce protection against 2, 4, or 9 subtypes and increase the cost in greater protection. The CDC advises using the 9-valent vaccine because of greater prevention capability and cost effectiveness. HPV vaccination is recommended for females 11 to 26 years of age and for non-immunocompromised males ages 11 to 21. But vaccination is recommended until 26 years of age for immunocompromised males and men who have sex with men. Originally released as a 3-dose series, the CDC now advises 2 doses are sufficient for protection from the most dangerous HPV strains. Prevention of HPV acquisition in young adults is important because they are more likely than older adults to contract STIs, and the services of younger women are more vulnerable to HPV. Public health officials are hopeful that vaccination of boys and girls before they become sexually active will decrease the burden of HPV infection in the future. Preliminary data suggest the effects of widespread vaccination that began in 2006 are already becoming apparent. There are even some reports that vaccination of pregnant women can decrease vertical transmission during vaginal birth because maternal antibodies to HPV do cross the placenta. So, here is what's new about the human papillomavirus vaccine. A good spot to hit pause if you are unfamiliar. The immune system is prepared to eliminate the virus through immune response when previously vaccinated. When an individual has not been vaccinated, he or she may or may not be able to clear this viral infection, although most HPV subtypes are not associated with abnormal cellular growth. High-risk HPV subtypes cause cellular changes that can lead to cell proliferation, causing warts or cancers. So what is its true pathophysiology? HPV is a non-enveloped circular double-stranded DNA virus, one of the papovaviruses that belongs to the Papoviridae family. Transmission of the virus occurs through close physical contact with infected skin, mucosa, or fluids. However, the exact transmissibility of the virus into the cell is unknown. The initial infection follows trauma of the epithelium that allows the virus to reach and infect the basal cell of the epithelium, which appears to be supportive of viral propagation. Such minor trauma may occur during sexual intercourse. HPV may enter the nuclear DNA and change the expression of cell proteins, leading either to increased but non-cancerous cell growth or to unchecked cell growth. It is not exactly why some HPV serotypes are cleared from cells, whereas other serotypes cause cellular transformation. But immune response and other cofactors play a role. HPV infection may occur months to years before symptoms occur, such as warts and precancerous lesions. So, what are our clinical manifestations? Genital warts, Condylomata acuminata, are soft, skin-colored, whitish pink to reddish brown, discrete growths. They may occur singly or in clusters, may be broad at the base or pedunculated, and may be feathery or smooth. Sometimes the warts enlarge to form cauliflower-like masses on the male frenulum, glands, foreskin, urinary meatus, shaft, scrotum, or anus, and on the female labia, clitoris, perineum, vagina, or anus. Although the lesions are usually not painful, they may cause dyspareunia or painful intercourse, and may be friable and bleed easily. Some individuals complain of pruritus. Common locations for condylomata are on the vaginal introitus, on the shaft of the penis, and under the foreskin. However, warts can be in any location infected by HPV, along the reproductive tract, anus, and oropharynx. Laryngeal papillomas can occur in infants and children whose mothers had genital warts at the time of delivery. Clinical manifestations of laryngeal warts include stridor, hoarseness, an abnormal cry, cough, and respiratory distress. So here you're taking a look at the Condylomata acuminata. Precancerous changes related to HPV often do not have any visible manifestations and are not painful, hampering early detection. In addition, cervical and anal cancers may not cause symptoms until late into the disease process. Routine screening for cervical cancer was begun to increase early detection since clinical symptoms are minimal. So it's evaluation and treatment, therefore. Generally, diagnosis of Condylomata acuminata is made on the basis of clinical manifestation. Varicose, fleshy pink lesions caused by HPV must be differentiated from Condylomata lata, the whitish gray or flat lesions of secondary syphilis. Because HPV infection often accompanies other STIs, gonorrhea culture, chlamydia culture, serologic tests for syphilis, and vet mount for other vaginal microorganisms also should be performed. Treatment for external genital warts are considered cosmetic, not curative, and include patient-applied therapies and provider-administered therapies. Vaginal, urethral, or anal warts are treated in the clinic using topical medications, cryotherapy, or surgical excision. The CDC provides specific guidance on therapies based on wart location and pregnancy status. Cervical and anal warts require additional screening to exclude more extensive lesions. Successive treatment depends on response of the immune system. Surgical excision is the treatment for laryngeal warts in infants. Evaluation of infection with oncogenic strains is more difficult since infection is often asymptomatic until cancer is advanced. This is especially true for cervical cancer because of poor innervation of the upper pelvis, allowing cancerous masses to grow large before causing symptoms. The development of the papinocollo or pap smear helped reduce deaths related to cervical cancer by 80% since the 1950s. Ideally, persistent HPV infection can be identified to encourage greater screening for abnormal cellular changes. The appropriate screening for HPV infection is controversial because there are no guidelines delineating who should be screened for anal or oropharyngeal infection. There are guidelines on screening for cervical cancer in women, and these guidelines change frequently in response to new evidence and testing techniques. Following the development of the Pap smear, women are advised to have yearly Pap tests to detect cancer. Over time, however, it became apparent that while younger women have had abnormal Pap tests, they were often able to clear HPV infection and resolve cellular changes without treatment. Treatment of women less than 20 years of age provides little to no benefit in reducing later rates of cervical cancer, but results in pain, anxiety, and increased healthcare costs. Therefore, the United States Preventive Service Health Task Force, the American College of Obstetricians and Gynecologists, and many other national cancer agencies have recommended that pap smear testing begin only after 21 years of age. Women ages 21 to 29 should receive Pap testing every 3 years, whereas women 30 to 65 years of age may receive Pap testing with HPV screening every 5 years, or Pap testing alone every 3 years. After the age of 65 years of age, Pap testing and HPV screening are no longer recommended for women with previous normal testing results, since the risk of new malignancy is low. Women who have had a hysterectomy with removal of the uterine cervix for a non-cancerous condition do not need pap smears or HPV testing for the rest of their lives. Although the HPV vaccine does reduce the risk for cervical cancer, it does not change the frequency or need for PAP and HPV testing at this time. If the results of a Pap test are abnormal, the woman's cervix will be further evaluated using colposcopy, which involves applying acetic acid and using magnification to examine the cervix for changes indicative of cancer or precancerous lesions. HPV-infected cells will appear white when exposed to acetic acid. In some developing countries with limited laboratory facilities, this test alone is used to screen for cervical cancers. Following visual investigation of the cervix during colposcopy, the clinician biopsies suspicious areas for further investigation. Treatment of precancerous and cancerous lesions varies and involves removal or destruction of the affected cells through excision or ablation so they cannot continue to divide. Although infection with high-risk HPV strains is a risk factor for development of anogenital cancers as well as cervical cancers, there is not a consensus on screening for rectal and anal cancers. Anyone who engages in receptive anal intercourse is at risk for rectal acquisition of HPV and subsequent development of anal cancer. Women are about twice as likely as men to develop anal cancer, but men who have sex with men remain at risk. Hopefully, the need for treatment of HPV-related genital conditions will decrease as more children and young adults receive the HPV vaccine before becoming sexually active. That brings us to the molluscum contagiosum. Molluscum contagiosum is a benign viral infection of the skin in children and adults. For detailed information, you'll take a look at chapter 47. In adults, the disease is more commonly sexually transmitted and affects the lower abdomen, genitalial, and perianal area. Molluscum contagiosum in adults is most common in men 20 to 29 years of age and in those with multiple sexual partners. Treatment for sexually transmitted molluscum contagiosum is the same as that for the non-sexually transmitted form of the disease. The CDC also includes information on the regularly updated guidelines. Parasitic infections. Trichomoniasis. Trichomonas vaginalis, commonly known as trich, affects more than 3.5 million people in the United States and 11% of women older than 40, and is the most common non-viral STI in this region. The high rate of asymptomatic infection aids the spread of this pathogen. Male-female vaginal intercourse is the most common route of transmission, although sexual transmission is clearly the most common means of disease spread. Transmission through fomites is theoretically possible. So what is its pathophysiology? T. vaginalis is an anaerobic, unicellular, flagellated parasitic protozoan that adheres to and damages squamous epithelial cells. It is primarily spread through penile vaginal sex, although anal sex and oral sex could be potential routes of infection. Because the protozoan selectively affects squamous epithelia, the vaginal and urethral tissues in women are often infected, as are periurethral and greater vestibular glands. The endocervical canal is not affected because it is lined with columnar epithelium. In men, the urethra is the most common site of infection, although the protozoa called trichomonads also can infect the epididymis and the prostate. Uncircumcised men are more likely to become infected after exposure than circumcised men. There are no conclusive data that the rectum or the oropharynx is a reservoir for infection. So here you see a picture of the Trichomonas vaginalis. Our clinical manifestations. Manifestation of vaginal trichomoniasis range from none to severe. Up to 85% of the infected have minimal to no symptoms. Vaginal discharge and internal pruritus are the most common manifestations of infection. Dyspareunia and dysuria also are fairly common. Some women report an increase in symptoms immediately after menses. Vaginal secretion can be copious, frothy, malodorous, and yellow-green to gray-green. On examination, the vaginal wall may appear erythematous and sore. Small, punctured red marks, sometimes called strawberry spots, are sometimes visible on the vaginal walls and cervix. Most men with trichomoniasis are asymptomatic, but may have scant intermittent discharge, slight pruritus, and mild dysuria. So it's evaluation and treatment, therefore. All women reporting abnormal vaginal discharge should be tested for trichomoniasis. Again, our NAAT, that nucleic acid amplification test, is the most sensitive and specific method for detection of T. vaginalis infection. Samples for testing can be obtained from the woman's endocervix, vagina, and or urine. Samples for men ideally come from the penile meatus, but urine is acceptable as well. Self-collection of samples is acceptable. Some tests have even been shown to be accurately used in self-testing, which can aid diagnosis, especially in cases of recurrence. A microscopic examination of vaginal fluid mixed with saline was previously widely used to detect the presence of this protozoan, but with a sensitivity of just greater than 50%, it is much less accurate than the NAAT-based tests. However, this method can be used when other tests are unavailable or cost prohibitive. On microscopic examination, The ovoid microorganism is slightly larger than the polymorphonuclear leukocyte and has one rounded, flagellated end and one slightly pointed, flagellated end. The flagella give the trichomonads their characteristic twisting motility. When women are infected, their vaginal secretions have a pH higher than 4.5, and when mixed with the 10% potassium hydroxide, emit a fishy odor related to amine release, known as a positive whiff test. The treatment of choice for trichomoniasis is a single 2-gram dose of tinidazole or flagyl, with tinidazole achieving better cure rates. These drugs have intense side effects when taken with alcohol. Thus, individuals must be able to abstain from all alcohol products for 3 days after treatment. Sexual partners, even if asymptomatic, also should be treated. There are high rates of reinfection, and the CDC advises a 3-month follow-up after treatment for the test of cure. T. vaginalis infection in pregnant women is associated with an increased risk of preterm birth through unknown mechanisms that may be linked with inflammation. The 2-gram single dose of flagyl can be used to treat pregnant women. However, it is not clear if treatment improves outcomes, and flagyl therapy may actually increase the rate of preterm delivery. An alternative dosing regimen is available for lactating women, or the woman can abstain from breastfeeding for 12 to 24 hours after taking the drug. That brings us to scabies. Scabies is a common parasitic infection that can be spread by skin-to-skin and sexual contact. Transmission of scabies requires close skin-to-skin contact, which occurs between sexual partners. Scabies is more common in children and the elderly than in adults. However, sexual transmission is the most frequent cause of infection in adults. The pathophysiology of scabies was already discussed in chapter 48. So, what kind of clinical manifestations do we see? The classical symptoms of scabies is intense pruritus, which increases at night. Pruritus is a result of a reaction that is the presence of the Sarcopetes scabiei mite. This reaction may take weeks with initial infection, but only 24 hours if the person has been previously infected. The groin and buttocks are common locations for sexually transmitted scabies. The following figure shows the typical sites of scabies burrows. The typical burrows of S. scabiei is a short linear curved or S-shaped line. There may be a small erythematous excoriated larvae papule near the burrows. Secondary infections are common and are caused by scratching. Even after successful treatment, some individuals continue to experience pruritus for several weeks. So if you look at all the red marks, there you would see the distribution of the skin lesions for scabies. The forearms, the wrists, the underarms, the groin, along the abdomens, the inner thigh, bottom of the legs. And here is a picture of the scabies burrows. So, what kind of evaluation and treatment do we need? The diagnosis of scabies is often made clinically when risk factors are present. Microscopic identification of the mites, eggs, larvae, or feces is ideal because the symptoms of scabies can imitate many dermatologic conditions. Superficial scrapings from an intact papule or burrow can be observed under the microscope, and KOH application facilitates mite visualization. Preferred treatment is a topical application of 5% permethrin massaged into the skin and left for 8 to 14 hours, or ivermectin 1% dosed at a 200 microgram per kilo orally and repeated again in 2 weeks. Lindane lotion or cream also is effective if applied thinly to all areas of the body below the neck and washed thoroughly 8 hours after application. Close household and sexual contacts should be examined and treated if infected. Pregnant women should be treated with permethrin to prevent reinfestation. Clothing and bed linens should be washed and dried in a machine at a high temperature or kept away from the body contact for at least 72 hours. That leads us to pediculosis pubis. Pithyrus pubis, the crab louse, is one of the 3 species of lice that infest humans. P. pubis is commonly transmitted sexually and causes pediculosis pubis, also known as crabs. P. pubis is transmitted primarily by intimate sexual contact or by contact with infected linens. It is highly contagious. There is a 95% chance of contracting lice during a single sexual encounter. Fomites are a common method of infection because crabs can live away from the body for several days. The transfer of lice from pubic hair is probably mechanical, assisted by scratching, fingernails, and talons, rather than self-propulsion. Pubic lice usually infect the perineal and axillary hair, and occasionally the hair of the trunk, beard, scalp, and eyelashes. The pathophysiology. The crab louse has a 25 to 30-day life cycle that consists of 5 stages: an egg stage, 3 nymphal stages, and an adult stage, all of which occur on the host. The nights of crab lice are found glued to hairs. They are oval, 0.8 by 0.3 millimeter in length, and whitish, and they hatch in 5 to 10 days. In the adult stage, pubic lice are grayish, are approximately 1 millimeter in length, and have segmented body and claws to cling to hairs. They bite into the host's skin to feed on blood, causing itching and pain. So here you're taking a look at crabs. So what kind of clinical manifestations do we see? The mites are visible, facilitating self-identification of infestation. Symptoms range from mild pruritus to severe intolerable itching, depending on the individual's sensitivity to louse bites. Allergic sensitization occurs in about 5 days, when itching, erythema, and inflammation may worsen. Excessive scratching may lead to secondary infection. So what is its evaluation and treatment? The individual usually presents with a history of itching in the infected area. Because the lice and mites are visible to the naked eye, a thorough clinical examination permits definitive diagnosis. Pediculosis pubis is treated with either a 1% permethrin cream, rinse, and 1% lindane lotion, cream or shampoo, or with over-the-counter pyrethrin and pyperonal butoxide. For non-ocular infection, the pediculicide is applied to infected and adjacent hairy areas and washed off after a specific time. Remaining mites can be removed with a fine-toothed comb. Permethrin is the first-line treatment. However, drug resistance is widespread and increasing. Malathion and ivermectin are alternative regimens, although ivermectin does not adequately kill the eggs and requires a second dose, and malathion has multiple contraindications. Lindane is a higher level treatment and cannot be used by pregnant women because of the high risk of toxicity. Sexual contact from the past month should be treated, regardless of symptoms, and household contacts should be examined and treated if needed. Clothing, bed linen should be washed and dried at high temperature or kept away from the body for at least 72 hours. That leads us to sexually transmitted infections of other body systems. The effects of some STIs extend beyond the urogenital tract. Many disorders have varied methods of transmission that may include non-sexual means, although the major mode of transmission may be by oral ingestion or by direct contact with blood or body fluids. Infection can be transmitted through intimate sexual contact as well. Anal contact and physical damaging sex can increase the transmission of many of these infections. Among the most serious of these infections are acquired immunodeficiency syndromes, your AIDS, caused by the human immunodeficiency virus, or HIV, and hepatitis of all sorts. Worldwide, the main mode of transmission of HIV and hepatitis B is through sexual intercourse, but non-sexual exposure to infected blood and body fluids, especially through needle sharing, contributes to infection rates. The epidemiology, modes of transmission, pathophysiology, clinical manifestation, and evaluation and treatment of AIDS and hepatitis are discussed in detail in chapters 10 and 42. Sexual transmission of less serious but often debilitating infections, such as shigellosis and giardiasis, and systemic diseases, such as Epstein-Barr virus and cytomegalovirus infections, also can occur, although non-sexual transmission is more common. The following table here provides a list of several gastrointestinal and systemic infections that are known to be transmitted by intimate sexual contact, but in which the mode of transmission is primarily through other routes. So here is a good spot to hit pause if you're unfamiliar with infections with known sexual transmissibility, the main mode of transmission by other means. So again, your Shigella bacteria, your Campylobacter jejuni, your Giardia, your Entamoeba, and then your hepatitis A and C, your Epstein-Barr virus, your cytomegalovirus, and your Zika virus. So if we're talking about hepatitis is a liver infection that can be caused by 6 types of viruses, and that is A, B, C, D, E, and G. Each virus causes syndrome of acute icteric liver inflammation. Additional information about hepatitis was discussed in chapter 42. Of the 3 most common types, A, B, and C, the hepatitis B virus is most commonly transmitted through the sexual route. Hepatitis A, the most other predominantly enteric infection, may be considered an STI because of the anal-oral transmission, and vaccination is advised for men who have sex with men. Although hepatitis C virus is not recognized as an STI, the CDC has listed sexual exposure, particularly for individuals with multiple partners, as a potential risk factor. So here you see a chart in regards to the risk of hepatitis C exposure through the years up to 2001. Hepatitis B prevalence varies dramatically worldwide, with some geographic areas having more than 10% of the population infected with the virus. There are an estimated 19,000 new cases of HBV infection in the US each year, and more than 2.2 million people are chronically infected. Those at risk for HPV infection in the US are infants born to hepatitis-infected mothers, healthcare workers, individuals who have sex with HPV-infected persons, people with diabetes, and immigrants from areas of high HPV prevalence. Widespread screening of pregnant women and vaccination of all infants since 1991 have decreased the rate of infection in the US by more than 80% and are expected to have lasting effects into the future decades. Vaccination of healthcare workers also has decreased infection rates. Your transmission of HPV can occur through needle puncture, blood transfusion, cuts or abrasions in the skin, and absorption by mucosal surfaces. Direct contact with infected body fluids, such as semen and vaginal fluid, may transmit the infection. HPV can survive dry and outside the body for up to 1 week, making it easily infectious on fomites. In the United States, seropositivity generally increases with age. This is a function of more time for exposure as well as lack of routine vaccination before the 1990s. However, the younger a person is when he or she contracts the virus, the greater likelihood of chronic infection. Perinatal transmission of HPV is relatively common, especially in developed countries without routine screening of pregnant women. Neonates whose mothers are infectious have a 90% chance of becoming chronically infected with HPV during labor or delivery if they do not receive treatment, but a 1% risk if they receive adequate treatment. Infants of infected mothers should receive HPV vaccine and immunoglobulin against hepatitis within 12 hours of birth to reduce risk. The vaccine and immunoglobulin combination successfully prevents chronic carrier status in 99% of infants. Although HPV is in many maternal body fluids, it is not found in breast milk, and breastfeeding is still encouraged for mothers with HPV. More information about the pathology, diagnosis, and treatment of hepatitis is covered in Chapter 42. So if you need that refresher, I'll see if I can link specifically Chapter 42 to this chapter. Acquired immunodeficiency syndrome, epidemiology modes of transmission, pathophysiology, clinical manifestation, and evaluation and treatment of AIDS are discussed in detail in Chapter 10. I'll see if I can also link that chapter. Zika virus. The Zika virus is a single-stranded RNA virus from the Flaviviridae family, genus Flavivirus. Flavivirus. The virus is predominantly transmitted through bites from infected mosquitoes. However, vertical transmission easily occurs in infected women, and sexual transmission also has been confirmed. At this time, the exact mechanism of sexual transmission is not known, although shedding of the virus in semen is susceptible. The CDC is investigating the issue and advises safer sexual precautions for all sexual contact, including vaginal, anal, and oral sex, between an infected person and his or her partners, especially if a female partner is pregnant or plans on becoming pregnant. Infection with the Zika virus during pregnancy has been associated with severe fatal infection and associated CNS abnormalities. The Zika virus is able to infect human placental tissue and multiply within these tissues, spreading virus to the fetus, especially early in gestation. Although the exact pathophysiology is still unclear, post-mortem studies of affected fetuses demonstrates a high level of Zika virus within the fetal brain tissue, even higher than levels found in other tissue or in adult serum. It is thought that the presence of Zika virus within fetal central nervous system tissues disrupts normal cell development pathways, resulting in stunted brain and cranium formation, and causing the characteristic microcephaly associated with this infection. Microcephaly is a permanent birth defect that results in lifelong disability because of an inadequate development brain. The World Health Organization and the CDC are actively studying the disease, and scientists are working to understand the exact mechanisms of Zika transmission and cellular disruption. And that concludes our chapter here today. So I'll see if I can link both chapter 46 and chapter 10 accordingly. I thank you all for watching, and I'll see you all next time. Till then, take care and goodbye.